Advanced Psychology. Definition and classification of atypical behavior. Introduction. Most people have questioned their own and other people's thoughts, feelings and behavior at some time or another. It isn't always easy to explain why someone responds in a particular way. For example, loyal football fans often continue to attend matches, despite their team frequently being defeated. They do not enjoy watching the game each week but feel compelled to do so. Why do they do it? Other people find it difficult to understand why anyone would choose to spend their Saturday afternoons watching a group of men kick a ball around a field. It is even more complicated to try to explain behavior that is unexpected or bizarre, such as an individual shouting at an imaginary companion. Atypical psychology is concerned with behavior that is unusual, that is not typical of an ordinary person. It involves examining the possible causes and treatments of mental health problems. Some psychological difficulties are quite common, such as depression. Many of us will experience, or have experienced, a period of doubt and unhappiness. Other disorders occur less frequently, with long-term effects, such as schizophrenia. Individuals with schizophrenia sometimes hear voices in their heads and lose touch with reality. It is a fascinating area but one that is fraught with difficulties and controversy. Historical ideas of abnormality. In early ancient cultures, behavior that appeared beyond the control of an individual was explained by demonology. This is the belief that an evil spirit, such as the devil, had taken over the mind and body of the sufferer. Treatment would involve rituals, such as chanting or praying, or more aggressive behavior such as beating or starving the individual. The process is known as exorcism. The aim of exorcism was to force the evil spirits out of the sufferer's body. Hippocrates, 460–377 BC, is regarded as the founder of medicine and the first to regard mental illness as a disease with natural causes. He saw the importance of the brain in consciousness, intelligence and emotion. Hippocrates divided mental disorders into three categories: mania, melancholia and brain fever. His system can be seen as a very early and much simpler classification system than the one currently used today. He suggested very different treatment to exorcism, such as rest, peaceful surroundings and a good diet. Unfortunately, his understanding of the structure of normal brain functioning was completely inaccurate. He believed that mental health was dependent on four fluids in the body known as humors. An imbalance of these fluids, it was thought, produced disorders. Hippocrates was one of the earliest practitioners to believe in physical causes for mental ill health, which is known as somatogenesis. The progressive and humane view of mental illness did not continue, and throughout the Middle Ages a belief in demonology returned. Seriously disturbed individuals were thought to possess supernatural powers that could cause harm to others. As a result, there was an increase in violence and mistrust towards them, often ending in a trial for witchcraft. Historians have documented that many thousands of people were executed during this time for allegedly practicing witchcraft. Among those killed were the mentally disturbed. In the latter part of the Middle Ages the first asylums were created. These were buildings specifically used to house and care for the mentally ill. Early asylums were no better than prisons. The inmates were kept in filthy cells and treated more like animals than humans. The Priory of St. Mary of Bethlehem in London was one of these early asylums and became a great tourist attraction. Tickets were sold to view the violent patients, and the mentally ill became a source of entertainment. The term Bedlam, slang for Bethlehem, has since become associated with a place of extreme confusion and uproar. Some of the treatments devised at this time were no better than earlier efforts. For example, Deutsch 1949 describes a commonly held view that lunatics could be cured by extreme fear. One doctor had a coffin-like box for the patient, with holes drilled in it. The box was lowered into a tank of cold water and kept there until air bubbles stopped coming to the surface of the water. Many patients did not survive this treatment. It seems no different in principle than the ducking stool, used to determine whether someone was a witch in the early Middle Ages. Philippe Pinel, 1745–1826, is considered to be the first humanitarian practitioner in asylums for the mentally ill. He was in charge of a large institution in Paris and was determined to treat the inmates as individual and sick human beings rather than animals. He removed their chains and shackles, and allowed them to walk. Decay around the hospital grounds. Many patients who had been uncontrollable became calm and easier to manage. Pinel's methods, sometimes referred to as moral treatment, can be seen as a return to ancient Hippocratic ideals, sadly lost for many centuries. In England, the York Retreat was established by William Tuke in 1796. He provided a quiet religious atmosphere for the mentally ill in the grounds of a country estate. Patients could work in the gardens and take walks through the countryside. Attendants looked after them and talked with them about their difficulties. As attitudes towards mental health changed, it became apparent that mental health disorders were more common than had previously been acknowledged. Major building programs were undertaken in Europe and America to create large state-run asylums. These hospitals were responsible for the treatment of hundreds of patients. The intensive nature of moral treatment was unmanageable with such large numbers, and the approach fell out of favor. In the early 20th century, there was also a return to somatogenesis, as knowledge and understanding of human physiology increased. For example, a physical cause had been discovered for a common mental disorder known as general paresis. The venereal disease syphilis was found to cause a gradual decline in mental and physical health, leading to the delusions and hallucinations of general paresis, followed, ultimately, by death. Prior to this discovery, about 10% of inmates in asylums were diagnosed with the disorder. It is extremely rare today, due to the effectiveness of antibiotics in treating early symptoms of syphilis. Physicians, most notably Kraepelin, 1896, began documenting symptoms that regularly appeared together in different mental health problems. These are known as syndromes. Kraepelin proposed that the existence of syndromes suggested a different underlying physical cause for each distinct mental disorder documented. This was the beginning of the medical approach, and the concept of mental illness. Kraepelin proposed two major groups of mental illness: dementia praecox, which was an early term for schizophrenia, and manic depressive psychosis, which is now known as bipolar mood disorder. He believed that a chemical imbalance caused dementia praecox, an idea that is still under investigation. An irregular metabolism was thought to cause manic depressive psychosis. Kraepelin's method of classifying disorders became the basis for the system in use today. At the same time, a school of thought was emerging that attempted to understand mental disturbance in terms of psychological factors. Sigmund Freud studied a number of mentally disturbed individuals who had physical complaints, such as blindness, without any obvious cause. This led him to develop a theory based on psychogenesis, which is the belief that something is caused by psychological rather than physical factors. Later psychological approaches such as behaviorism, humanism, and the cognitive school also supported psychogenesis. The debate surrounding the psychogenic or somatogenic origins of mental illness remains today and is more commonly known as the mind-body debate. The work of mental health practitioners has also been divided between these two camps. The differences can be seen in the treatment methods and language used within each profession. Psychiatrists are medically trained doctors who have chosen to specialize in mental illness. They adopt a somatogenic approach and believe physical treatments, such as antipsychotic drugs, should be prescribed to patients. Psychologists, on the other hand, are people who have a postgraduate degree in psychology and favor a psychogenic approach. They are more likely to use psychological interventions such as behavioral or cognitive therapy, with clients. Clinical psychologists are trained in assessment and diagnosis within the hospital environment but are not qualified to prescribe drugs. While, historically, there has been conflict between these two schools of thought, many practitioners today would favor an interactionist approach, combining both psychological and physiological knowledge and understanding. As a result of developments in somatogenic treatments in the 1950s and 1960s, such as antidepressant and antipsychotic drugs, the need for large mental hospitals to house long-stay patients was significantly reduced. During the 1980s, many specialist psychiatric hospitals were closed and community care was introduced. Patients now often receive treatment and care as outpatients, with regular appointments to see either a clinical psychologist or a psychiatrist. Alternatively, a community psychiatric nurse can visit people in their own homes. Definitions of abnormality. Psychologists and psychiatrists are involved in the day-to-day care and treatment of people with a variety of mental health problems, whose behavior is described as abnormal. However, it is not easy to define exactly what is meant by abnormal, or atypical, behavior. Statistical infrequency. Abnormal behavior could be defined as behavior that is statistically infrequent in society. This approach is most useful when dealing with human characteristics that can be reliably measured, such as height. Most people's scores will cluster around the average, with fewer very small or tall people. This is known as normal distribution. Gathering data about mental health problems is common. For example, anorexia is known to affect 1% of the population, whereas bulimia affects 3%. Both behaviors are therefore statistically infrequent. The approach is easy to understand and assumes that normal behavior is average behavior. Violation of social norms. A second approach involves considering behavior that differs from the usual, or norm, in society. It introduces the concept of what is desirable and expected behavior in different circumstances and situations. A situational norm dictates what kind of behavior is acceptable in a given situation. For example, stripping naked is acceptable in the shower room but not in the gym. A developmental norm indicates the kind of behavior that is acceptable at a certain age. For example, young children can cry loudly when they are bored, but A-level students cannot. Abnormal behavior is therefore defined as any behavior that transgresses social norms. Practical problems. The definition is too broad and would include behaviors that are against social norms but are not universally considered to be abnormal, such as smoking. Social norms also change over time. For example, it is much less socially acceptable to smoke cigarettes today than it was 20 years ago. Smoking was allowed on public transport and in cinemas and the workplace. Definitions of atypical behavior would have to be constantly revised to keep up with changes in social norms. Also, many people with mental health problems are not obviously breaking any social norms. For example, someone with a phobia of heights is unlikely to behave in an unlawful or undesirable way. Ethical dilemmas. A major difficulty with this approach is that it defines anyone who goes against social norms as abnormal and therefore mentally disturbed. People could be defined as abnormal because of their sexual preferences, religious beliefs or political ideas. For example, homosexuality was defined as a mental illness until 1973. Social pressure, from many professionals in the field of mental health and gay activists, was needed to change the definition. Some researchers believe that adherence to social norms can actually create mental health problems. For example, the incidence of anorexia among young women has been linked to the social pressure to be thin. Cultural differences. The term culture means a set of values, beliefs and attitudes shared by most members of a community. An individual's behavior is governed to some extent by the culture he or she lives in. What may be acceptable in one culture could be perceived as a severe social problem in another. For example, voice hearing is an acceptable part of some religious faiths, yet is perceived, among the psychiatric community, as a symptom of mental illness. Behavior can be perceived as abnormal, when in fact it is simply culturally different and normal to that culture. Kaiser et al. 1998. Claim that psychiatrists are now encouraged to be aware of cultural differences when assessing patients. The manual they use to diagnose mental health problems outlines conditions that appear most often in specific cultures, as well as some cultural variations in the way symptoms are described. For example, in some cultures, depression is expressed as a physical pain, other cultures describe depression as a feeling, such as sadness. Practical problems. Developing detailed knowledge of other cultural groups would be highly time-consuming. Within each culture there are a number of subcultures, which are any section of society holding different views and attitudes to the dominant culture. For example, younger people may have a different set of attitudes to older members in society. As cultures and subcultures also develop and change over time, maintaining knowledge would be a very complex, ongoing process. Ethical dilemmas. Attempting to define abnormality is in itself a culturally specific task, centered as it is on the notion of mental health care professionals who diagnose and treat patients. Other cultures may be more accepting and tolerant of unusual behavior within their society. For example, Lynn and Kleinman, 1988, found that non-industrialized societies had higher recovery rates for people displaying symptoms of schizophrenia. They believed this was because the social environment was more supportive and allowed people to recover at their own pace. Research has cast doubt on whether awareness of cultural differences has contributed to making an accurate diagnosis, as Kaiser et al. 1998 claimed. Distress. Many people with mental health problems experience intense unhappiness and anxiety. Sometimes psychological problems can cause physical complaints, and patients visit their doctor believing they are physically unwell. Rather than labeling an individual's behavior as statistically infrequent or socially undesirable, abnormality could be defined as thoughts, feelings or behaviors that distress the individual. This seems a kinder definition because it includes the experiences of the individual sufferer. The approach also acknowledges the need for treatments to alleviate personal distress. Practical problems. There has been a practical difficulty in producing a reliable way of measuring distress. Each individual may show and experience their distress in different ways. For example, a highly disturbed individual may choose to withdraw and not report distress, while another person might react by attempting suicide. Ethical dilemmas. Some mental health problems do not cause distress to the individual. For example, during the manic phase of bipolar disorder, the patient can feel marvelous and strongly resist any attempt at treatment. This type of disorder is called a psychosis. The sufferer has a severe mental disturbance that has seriously impaired their emotional responses and thought processes. The individual may be in need of help and protection, despite a lack of any obvious distress. An alternative view could consider the amount of distress caused to other people by the individual's unusual behavior. For example, anorexic patients are often brought to the attention of professionals by deeply concerned parents. Using this approach, treatment can be given to patients who might otherwise resist it, or deny they have a problem. Maladaptiveness. Another way of defining abnormality is to look at the consequences for the individual. Adaptive behavior is that which enables an individual to thrive in their environment. Mental health problems can seriously affect all aspects of an individual's life. They can disrupt social relationships, work, academic study and the ability to achieve personal goals. Abnormality can therefore be defined as maladaptiveness, where the thoughts, feelings and behavior experienced interfere with progress in the world. Practical problems. This definition could be applied to all of us at some point in our lives. For example, excessive partying during an A-level course is likely to affect the overall grades achieved. Maladaptiveness can perhaps be accepted as normal behavior at certain stages in our lives. This creates the problem of trying to decide how much maladaptiveness is too much. Ethical dilemmas. The main difficulty with this approach is whether or not the patient, their family or a mental health practitioner is responsible for defining maladaptiveness. For example, a person may want to lead a very isolated and secluded existence. The definition assumes that there is a normal way of living, excluding individual choice to live outside the mainstream. Also, some mental health problems cause personal distress to the individual, without having terrible consequences. For example, claustrophobia, a fear of enclosed spaces, may cause an individual to seek treatment although the behavior does not have a major impact on their work, social or personal life. Diagnosis and classification. The medical model. The best-known explanation for abnormality in our culture is the medical model. Mental disorders are regarded as illnesses, caused by biological factors such as infection, genetics, brain chemistry or brain damage. For example, in Alzheimer's disease, the brain tissue irreversibly deteriorates, initially causing difficulty with concentration and memory. As the illness progresses, the personality of the sufferer is affected and they begin to display psychological disturbance. This type of mental illness is known as an organic disorder because it has a clear physical cause. Autopsies of Alzheimer's patients show consistently similar physiological changes in the brain. Clear biological causes of other mental disorders, such as anorexia nervosa, have yet to be identified. These types of illness are known as functional disorders. There is no demonstrable physical cause, but something has gone wrong with the way the person functions, or acts, in the world. Many psychiatrists believe that medical science will eventually identify the physical causes of functional disorders. The main practitioners in the somatogenic approach are psychiatrists. They are medical doctors who have specialized in the area of mental health. Psychiatrists work in hospitals, can give physical examinations, and diagnose both mental and physical illness. They also decide on what medical treatment is needed. A psychiatrist can prescribe drugs, electroconvulsive therapy, ECT, and, in extreme cases, brain surgery. Many patients, and their families, take comfort from the idea that their difficulties are due to biological factors beyond their control. The medical model means that the individual is not held personally responsible for their abnormal behavior. The approach can be seen as a more caring and humane definition of abnormality, with a blameless victim who requires care and treatment. However, there are also some difficulties. Practical problems. The medical model presents a practical difficulty in diagnosing mental health problems. Identification is largely dependent on the interpretation of the individual patient's symptoms. With physical illness, the patient can describe symptoms, for example, a pain in the foot, and the doctor can observe a physical sign, a swollen ankle. Objective medical tests, such as X-rays, can be undertaken to establish the condition of the patient. With mental illness, there are often no physical signs of any disease, and critics of the approach would argue that some form of subjective, or value, judgment is made. Ethical problems. On the basis that mental illness can lead to a loss of control and responsibility, the Mental Health Act 1983 allows for the compulsory detention and treatment of the mentally ill if they represent a danger to themselves or others. The sick individual can get treatment and support, and will be closely monitored. However, critics from the anti-psychiatry movement have argued that this loss of rights is unethical and leads to discriminatory practice. The medical model and social norms. In the 1960s, a new school of thought developed known as the anti-psychiatry movement. Schasch, 1962, was a major critic of the medical model. He claimed that, as there were no physical signs of brain disease in many disorders, it was inaccurate to describe problems in living as mental illness. Schasch thought the medical definition of mental illness was flawed, just as earlier ideas of demonology were. The concept of illness, or demons, existed because the prevailing culture accepted it as a valid explanation, without any real evidence to support it. In the Middle Ages, people who deviated from social norms were tried and punished for witchcraft. In the 20th century, psychiatry labeled them insane, and excluded them from society by sending them to a mental institution. Schasch therefore saw medical treatment as another form of punishment for those who would not conform to social norms. Some medical treatments for mental health problems in the 1960s were undertaken with aggressive people who violated social norms. For example, Taylor 1992, reports that 38,000 leucotomies were undertaken in 1968, compared to just 18 in 1991. A leucotomy is a surgical procedure that involves cutting away the brain tissue connecting the frontal lobes. It causes permanent changes in behavior, including intellectual impairment, lack of energy, personality changes, and in some cases death. The main advantage of psychosurgery was that it made patients much easier to control. Many of these operations were undertaken without the consent of the patients, because they were believed to be incapable of making decisions for themselves. In England and Wales, the use of psychosurgery is now governed by the Mental Health Act, 1983. It can only be undertaken as a last resort and with the patient's consent. The work of Schasch and other members of the anti-psychiatry movement has contributed to a change in social norms surrounding the care and treatment of people with mental health problems. The medical model and cultural differences, as Sterling and Hellawell, 1999, point out. Many psychiatrists in the UK are middle class, male and white. Mental health practitioners are therefore likely to be subject to their own cultural bias. This means that people tend to favor their own view of the world and perceive alternative ways of behaving as abnormal. For example, Sabin 1975, found cultural bias when clinicians used assessment techniques with non-English speaking patients such as Mexican Americans. The patient's emotional problems and symptoms were often misunderstood. This may explain why there is a much higher incidence of serious mental illness, such as schizophrenia, diagnosed in ethnic minorities in the UK and the United States. In physical illness, the cultural differences between a patient and doctor would not contribute to the diagnosis made, because objective measures, such as urine samples or blood tests, are undertaken to confirm the illness. The medical model and maladaptiveness. The idea that mental disorders affect the way a person functions in the world has been acknowledged in the medical model. The diagnosis of mental illness in America since 1980 has involved assessment of the psychological, social and occupational functioning of the individual in the months prior to the illness. Collecting information about a patient's level of functioning can help the psychiatrist to make a more informed decision about whether treatment is needed. While this assessment has been widely welcomed, some critics, for example, Davison and Neal, 2001, have argued that it is a further subjective measurement which assumes that there is some form of normal, or average, functioning. In addition, receiving a psychiatric diagnosis in itself can create negative consequences for the individual. Davison and Neal, 2001, point out that, when a person has been diagnosed with a serious mental illness, friends and loved ones often begin to react differently towards them. Employment may be difficult to find. Adaptive functioning can be compromised as a result of the diagnosis. The medical model and distress. To come to the notice of a psychiatrist, the patient, or their family or friends, must have reported distress. This definition of abnormality is therefore apparent in the medical model. However, Lawing 1967, argued that, although people who are considered to be mentally ill are often unpredictable, it is usually other people who are disturbed by their behavior, rather than the individual sufferers themselves. This raises ethical issues about the individual's right to behave as he or she pleases.